The student.
Yes, ma'am. You don't move. Sorry.
Yeah, the class is live stream now.
Please start.
Good evening, everyone. Welcome to the ISA National PG online class session. This is Dr. Swati, one of the screen coordinator, consultant, TSRTC Hospital, Hyderabad. A warm welcome to everyone for today's session. Today's topic is temperature monitoring during anesthesia and case presentation of an unusual case of perioperative hyperthermia. Body temperature is one of the important vital signs. Both hypothermia and hyperthermia can be deleterious. Perioperative temperature monitoring can help to prevent and detect these conditions. Before we move into the session, let us invoke the blessings of Ma Saraswati Devi with the Saraswati Vandana. Now, I would like to invite Dr. Sukhminder Bajwa, sir, Honorary Secretary, ISA National, to speak a few words. Over to you, sir.
Thank you, Dr. Swati. I think this topic today is of paramount importance, as lately we have seen a very almost a surge in the cases of malignant hyperthermia, or hypothermia across India, and few deaths have also been reported. The ISA has also swung into action. Because of these cases, new policy matters are being drafted, and I think we are going ahead with the availability of dantrolene in almost every city of India. Although its cost is very, very high, we are working out with some agencies and companies to bring it to a subsidized level so that we may be able to afford and save lives, especially young lives. People who lost lives are very young people. And other policy matters are also being discussed at the government level. So, and this monitoring of temperature is very, very important. I think with the availability of the newer gadgets in our workstations, you can always see the surge in the temperature immediately, rather than just going by the traditional methods. So this is a fact, the advantage of the advancements in our anesthesia equipment and surveillance and monitoring gadgets and standards. So I think the initial rise itself is very, very important to give you a warning sign, and almost you can still play us to some extent damage control role in those type of cases. And there are many queries also regarding how to prevent it, how to go about it, what are the exact limitations of our monitoring these temperature parameters during the operative procedures. It's very, very difficult, especially in the resource limited nation of ours. How many temperature probes, how much type of temperature probes, at what surface areas we can monitor the temperature rising, and so many things are there. So many queries are there. I think this is the right time to dwell upon this topic in our classes also. So we are having a dual advantage today, that's regarding the malignant hyperthermia as well as the temperature monitoring. So Dr. Nilamri Atkim and her team is there. So I think, Dr. Swati, it's now time to introduce the faculty for today's classes also.
Yes, sir. Thank you, sir. Now, I would like to request Dr. Durga, my co-screen coordinator, to welcome our esteemed faculty members and to outline the format and rules for today's session and to carry the session forward. Over to Dr. Durga.
Thank you, ma'am. This is Dr. Devi Durga. Good evening, everyone. I'm consultant, Gemcare Polymy Hospitals, Hyderabad. I take the pleasure to welcome the moderators for today's session, Dr. Neelambari ma'am and Dr. Sachin sir. Neelambari ma'am is a professor and HOD of the department Anesthesiology, VM Government Medical College, Sholapur. Ma'am has 17 years of teaching experience and with a special interest in regional anesthesia. Ma'am has been awarded the best poster in ISOCON 2003 with 8 publications in national and international journals. We welcome you, ma'am. Dr. Sachin sir, Associate Professor, VM Government Medical College, Sholapur, with 5 years of teaching experience and special interest in high-risk cases and labor analgesia. Sir has 3 publications in national and international journals. We welcome you, sir. Now, I kindly request the audience to remain muted and keep their video off throughout the session and can type their queries in the chat box. Now, I request Dr. Neelambari ma'am and Sachin sir to take over the session.
Thank you, Durga. Now, I would like to ask our President, Dr. Manogya, to start with the case presentation in today's session.
Good evening, everyone. I am here to present the topic on unusual case of perioperative hyperthermia. I'll be sharing my screen now. So my patient, he is a 15-year-old male. He's posted for bilateral mastectomy in a case of gynecomastia. The patient presented with a history of enlarged breast tissue on both the sides since few years. There was no history of pain associated with the swelling or any impairment to activity. The swelling caused a lot of psychological distress to the patient and made him the victim of bullying. But there is no history of taking any psychiatric medications or counseling for the same. The family history of consanguineous marriage in the parents is present. The pre-anesthetic checkup was unremarkable. The patient was categorized as American Society of Anesthesiology Grade 1 and posted for bilateral mastectomy. The preoperative investigations consisting of complete blood count, the renal function test, the liver function test, and the serum electrolytes were all within normal limits. The electrocardiogram showed normal sinus rhythm. On physical examination, the patient was averagely built, weighing 45 kilograms. His general condition was fair. His vitals at that time were heart rate was 80 beats per minute, the blood pressure was 110/70 millimeters of mercury, and the saturation was 99%. The airway examination was adequate, and the systemic examination was unremarkable. Plan of anesthesia was general anesthesia. After confirming the NBM status and taking written informed consent, the patient was taken into the operation theatre. Multi-para monitors were attached. 20 gauge angiocatheter was secured and IV fluids were started at 20 ml per kilogram. The heart rate at this time was 90 beats per minute, blood pressure 110/70 millimeters of mercury, and the saturation 98%. Patient was pre-medicated with injection midazolam 1 mg, injection glycopyrrolate 0.2 mg, injection ondansetron 4 mg, and injection fentanyl 75 microgram IV. The patient was induced with injection propofol 100 mg given in aliquots and injection succinylcholine 75 mg IV. After the disappearance of the fasciculations, direct laryngoscopy was attempted, where the mouth opening seemed inadequate, and hence the patient was switched back to mask ventilation. Additional bolus of injection propofol 50 mg was given. After 2 minutes of mask ventilation, direct laryngoscopy was performed easily. The patient was then intubated orotracheally with ETT number 7.5 mm. Injection vecuronium 3 mg IV was given, and the patient was maintained on a gas mixture of oxygen, nitrous oxide, isoflurane with positive pressure ventilation via standard anesthesia workstation. For 1 hour after the induction, the patient maintained a heart rate of 90 to 100 beats per minute. The blood pressure was around 110/70 to 120/80 millimeters of mercury, and the saturation was 99%. 70 to 75 minutes after the induction, the heart rate shot up to 120 beats per minute. The saturation fell to 94% and the blood pressure rose to 130 upon 90 millimeters of mercury. Assuming a lighter plane of anesthesia, injection propofol bolus was given and the isoflurane dial concentration was increased to 1.2%. The nitrous oxide was discontinued immediately and patient maintained on 100% oxygen. For analgesia injection, paracetamol 1 gram IV was given. On palpation, the skin was found to be warm. Axillary temperature was noted to be 38.5 degrees Celsius. Cooling measures were immediately started. Tachycardia continued with heart rate being 120 to 130 beats per minute. The blood pressure was 130 upon 80 millimeters of mercury and saturation was 98% on 100% of oxygen. The surgery lasted for around 90 minutes. The surgeons had done a bilateral breast tissue excision. Isoflurane was switched off. The patient was having tongue movements, spontaneous respiratory efforts, and limb movements. He was reversed with injection neostigmine 2.5 milligrams IV and injection glycopyrrolate 0.4 milligrams. 100% oxygen was continued. 10 minutes after the reversal, due to inadequate muscle power and inadequate consciousness level, patient was not extubated. Heart rate at this point was 130 to 140 beats per minute. The blood pressure was 130 upon 80 millimeters of mercury and saturation 100%. Patient was still febrile to touch. The temperature measured at this point was 38.5 degrees Celsius. Call for senior help was immediately sent. The cooling measures started earlier were continued with cold sponging and cold IV fluids and IV ice packs along the axilla and the groin. The patient went into supraventricular tachycardia. Injection adenosine 6 milligram IV was given, followed by 20 ml of IV push. Immediately, an ABG sample was sent. Patient had developed ventricular tachycardia on cardioscope, which was pulseless in character. Chest compressions were immediately started. Injection adrenaline 1 milligram IV was given stat and continued every 3 to 5 minutes, followed by IV push. In the meantime, we had the defibrillator brought in. 200 joules of BC shock was given. In the meantime, anesthesia workstation was changed and patient hyperventilated on 100% oxygen. Patient went into asystole. The chest compressions were continued. After 5 cycles of CPCR, the patient was revived. ECG showed sinus rhythm, but the blood pressure was non-recordable. We had secured a central venous line in the right IJV by this time and started injection noradrenaline 16 milligrams in 50 ml of NS at 10 ml per hour. After this, the heart rate was 100 beats per minute with blood pressure being 90 upon 60 millimeters of mercury. The patient was then shifted to the ICU for further management. This is an ABG sample sent earlier, which shows mixed metabolic with respiratory acidosis. Injection soda bicarbonate correction was immediately started, 0.5 to 2 milliequivalents per kilogram. Hyperkalemia correction was also given. We had earlier sent a CPK-MB sample, which we had received posthumously, which shows 12.7 nanogram per ml, further strengthening our diagnosis.
So, Manogya has presented here this case, which was started with as a ASA1 and with our routine induction and anesthesia management. But at the after 70 to 75 minutes, abnormal rising pulse rate was noted and followed by rising temperature. So, Manogya, what is your provisional diagnosis here?
And based on the clinical scenario observed, I would say that the patient most likely was of malignant hyperthermia. However, it is just a provisional diagnosis and not a definitive one, as the confirmatory test had not been done. Confirmatory test being the muscle biopsy and in vitro contracture test.
Yes. So, what is the other differential diagnosis which we can consider here?
Ma'am, other differentials would be anaphylactic reaction, myotonic crisis, thyrotoxic crisis, pheochromocytoma, or myotonic crisis or perioperative stroke. Muscular dystrophy is also present in such a picture. If the patient had any history of consuming antipsychotics, typical antipsychotics like haloperidol or prochlorperazine, I would also think of neuroleptic malignant syndrome.
Yes.
As we think that this hyperthermia is a very rare condition. Can you elaborate what is the incidence of malignant hyperthermia?
Sir, so far in India, only 8 confirmed cases of malignant hyperthermia have been reported. It could be due to lack of awareness or because we lack a national registry for the same. If we look at the Western data, the incidence of malignant hyperthermia in children, it is 1 is to 15,000 anesthetics. And in adult patients, it is 1 is to 50,000 to 1 is to 1 lakh anesthetics.
So, what we can rule out while we take history of any patient, especially teenage male patients posted for any surgery, can we have some view to rule out some factors so as to know about possibility of such muscle disorders or possibility of malignant hyperthermia?
Ma'am, so there are no specific tests that we can do to preoperatively rule out malignant hyperthermia. However, we can elicit some significant history. Like we can ask the patient if they have any close relatives who had passed away due to eventful anesthesia exposure, if there hasn't been any mortality after exposure to any anesthesia. Then we can ask if we can see if the patient has any associated conditions like scoliosis, if they have any congenital hernia, or if they have any strabismus. Then we can ask for any history of exercise induced rhabdomyolysis or any exertional heat stroke in the past.
What are the main triggering factors for malignant hyperthermia?
So there are just two triggering factors for malignant hyperthermia. One is volatile anesthetic agents, and second is depolarizing muscle relaxants like succinylcholine.
Yes. So, Manogya, what are the differential diagnoses when we come across clinically? Patient has tachycardia, hypertension, and rising EtCO2 levels.
Ma'am, if the patient has tachycardia, hypertension, and rising EtCO2, first I would like to rule out the common causes, which include inadequate depth of anesthesia, that's awareness, inadequate analgesia, rebreathing, CO2 absorber being exhausted. Once I've corrected these measures, and if still these symptoms persist, I would think of rarer causes like pheochromocytoma, thyrotoxicosis, neuroleptic malignant syndrome, myotonic crisis, ecstasy, anemia.
Yes.
You have mentioned the differential diagnosis for the clinical presentation. And you have mentioned that your clinical diagnosis is malignant hyperthermia. Okay. So how will you clinically diagnose?
Your audio is blur and it is echoing, sir.
How will you clinically diagnose malignant hyperthermia?
So the clinical diagnosis of malignant hyperthermia would be that there would be sustained jaw rigidity. Then there would be rise in body temperature up to like 1 degree Celsius every 5 minutes up to 40 degrees Celsius. Then there would be the presence of fall in saturation despite increasing FiO2. Then there would be rise in EtCO2 on the monitor. Along with cardiovascular instability, presence of dysrhythmias, and skeletal muscle rigidity.
If suppose on operation table you suspect that this can be a case of malignant hyperthermia, then how will you proceed with your immediate clinical management there?
Ma'am, first for the immediate management, I would call for senior help. I would stop all the triggering agents, immediately try to change the breathing circuit, change the CO2 absorbent if possible. I would continue supportive measures like giving 100% oxygen, giving inotropic support if needed. If there is any dysrhythmias, if indicated by ACLS algorithm, then I would go for defibrillation. In the meantime, I would arrange for Dantrolene if possible. I would start with cooling measures, which include ice packs along the groin and the axilla, peripheral cooling, cold sponging, stomach and bladder lavage with cold fluids, irrigation of the surgical site if possible with cold fluids, and IV fluids also will be cold. Then I would send immediately the blood sample for analysis of arterial blood gases, for serum electrolytes, as well as the creatine kinase levels, which would help me in further management. I would continue IV hydration 10 to 20 milligrams ml per kilogram. Then I would check for the blood sugar levels and correct it if needed. That would be my immediate management. Once the patient has stabilized, then I would consider for the further management, like if there is any possibility of sending the muscle biopsy sample for IVCT. If the patient is hemodynamically stable, then we can consider the other options.
You heard of malignant hyperthermia syndrome? What it is?
Sorry, sir.
What is malignant hyperthermia syndrome?
Yes. Malignant hyperthermia syndrome is an acute, uncontrolled, increased skeletal muscle metabolism released in heightened oxygen consumption, lactate formation, rhabdomyolysis, heat production. The hallmarks are rise in temperature 1 degree Celsius every 5 minutes up to 40 degrees Celsius, and rise in EtCO2, arrhythmias, and skeletal muscle rigidity.
What is the earliest sign of malignant hyperthermia? You can know.
The earliest sign of malignant hyperthermia is presence of masseter muscle spasm after administration of succinylcholine. The masseter muscle and the lateral pterygoid, they are supplied by slow tonic fibers which respond to succinylcholine in the form of a contracture. This response is exaggerated in patients who have malignant hyperthermia. So the anesthetist will feel that there is a tight jaw followed by a very tight jaw and a very rigid jaw. It's also called as jaw of steel.
Jaw of steel. Yes.
Yeah. Now you have mentioned that
masseter spasm, if you encounter, then how will you proceed further?
Sir, if I come across a patient who has a very rigid jaw, first the initial step will be call for help. Then I would look if I'm suspecting malignant hyperthermia, I would shut all the triggering agents. I will turn off the volatile agents and give 100% oxygen. Then I will see if the procedure is elective or emergency. If it's an elective procedure, we will abandon the procedure and shift the patient to ICU for observation for at least 24 hours. And if it's an elective surgery, then if it's an emergency case, then I might continue the case on TIVA, that is total intravenous anesthesia. We can use propofol 100 to 200 microgram per kg per minute. We can use etomidate, barbiturates, benzodiazepines, opioids, non-depolarizing muscle relaxants, and if possible, even regional anesthesia can be used.
What is the pathogenesis of malignant hyperthermia?
Ma'am, malignant hyperthermia, it is an autosomal dominant condition and it has variable penetrance. It occurs because of mutation in the MHA gene. The most common gene is MHS1 gene, which is located on chromosome 19q13, and 50 to 60% cases have mutation in this. So when we talk about normal muscle contraction, there is excitation contraction coupling. So a wave of depolarization, it comes to the motor neuron. It releases acetylcholine. The acetylcholine crosses and goes to the acetylcholine receptors. And there is generation of action potential at the motor end plate. This action potential will propagate, and the sarcolemma has invaginations, which is T tubules. It will go to the T tubules, and from there it will go to the sarcoplasmic reticulum. The sarcoplasmic reticulum has ryanodine receptors, which will open up after the depolarization has occurred and cause efflux of calcium from sarcoplasmic reticulum to the cytosol of the muscle. This calcium will cause muscle contraction. But in patients of malignant hyperthermia, there is mutation in this gene. So there is abnormal ryanodine receptors. So whenever the patient is exposed to triggering agents like volatile agents or succinylcholine, there is abnormal structural change in the ryanodine receptor, causing sustained opening of the ryanodine receptor, causing increased efflux of calcium. Because of that, there will be sustained muscle contraction leading to rigidity, hyperthermia. There will be increased aerobic metabolism, causing increased CO2, metabolic acidosis. Once the oxygen and ATP is used, there will be anaerobic metabolism, causing increased lactic acidosis. And if the muscles are increased because of increased contraction, there'll be rhabdomyolysis, which will cause hyperkalemia, myoglobinuria.
Yes.
As it
As it
is
is
a rare
rare
disease,
disease,
do there
do
are
there
any diagnostic
diagnostic
tests
tests
for
for
malignant
malignant
hyperthermia?
hyperthermia?
Yes, sir. The diagnostic tests for malignant hyperthermia include two types. One is in vitro muscle testing, and the other one is molecular genetic testing. In vitro muscle testing, there are two tests that can be done. One is given by the North American Malignant Hyperthermia Group, which is the caffeine halothane contracture test, and the other one is the in vitro contracture test, which is given by the European Malignant Hyperthermia Group. Both of them follow the same principle that on exposure of volatile anesthetic agent, in this case halothane, there will be contracture in these patient in the muscles of this patient. So what is done is that the patient has to go to laboratory because the muscle biopsy has to be processed within 4 hours. So once the patient goes to the laboratory, the muscle biopsy is taken from the location such as vastus medialis or the lateralis primarily. If that is not possible, then the rectus muscle can also be taken. Once the biopsy is done, then this muscle is treated and readied for the testing, where the 2 gram of the muscle is taken and exposed to different concentrations of caffeine as well as halothane, and in the in vitro testing, caffeine along with halothane, and response is checked. For caffeine, if the contracture normal should be 0.3, if the contracture is more than 0.7, then it is supposed to be confirmatory. On exposure to halothane, it is supposed to be confirmatory for malignant hyperthermia. Then the other part is the molecular testing. So far we have only found out 3 particular genes, among which we consider to be of the vast pool which are responsible for malignant hyperthermia. They are the CA and CA1S gene, the RYR1 gene, and the STAC3 gene. So they do the genetic testing of these patients and look for any mutations in these particular genes. However, these are not definitive, as in a negative genetic test does not rule out malignant hyperthermia if the patient is coming from a family of malignant hyperthermia, or a patient is coming from a malignant hyperthermia susceptible family, because still genetic testing the horizon has to be broadened in such a case.
Right. So you have mentioned that the treatment part of malignant hyperthermia. So what is the drug of choice in case of such malignant hyperthermia?
Ma'am, the drug of choice for malignant hyperthermia is dantrolene sodium. It is a hydantoin derivative. The mechanism of action is earlier it was thought that it inhibits the ryanodine receptors directly and decreases the efflux of calcium. But now it is suggested that it might inhibit the key protein-protein interaction of the ryanodine receptor, thereby causing direct muscular weakness. The formulation, it comes in 2 formulations. One is Dantrium and another is Rhinodex. Dantrium, it comes as 20 mg dantrolene with sodium hydroxide to maintain the pH of 9.5, so that the drug will dissolve in it, and it has 3 grams of mannitol, which will convert it from hypotonic to isotonic solution. This is constituted in 60 ml sterile water, and it can be given at the dose of 2.5 mg per kg for over 5 to 10 minutes, and it can be repeated over 5 to 10 minutes, and 1 mg per kg has to till the symptoms subside or the EtCO2 becomes normal. And after that, we'll give it at 1 mg per kg for over 6 hours, after every 6 hours for 24 hours. Another is Rhinodex. It comes as a formulation of 250 mg of dantrolene with 0.125 gram mannitol, and it is dissolved in 5 ml sterile water. The cost of each vial is about 12,500. So if we have to give an adult dose, the cost might go up to 1.5 lakhs for just the loading dose.
Yes, because of very high cost, as Bajwa sir has already pointed out, this availability of this drug becomes very problematic. And so, sir will explain us regarding the future plan for making it available at many cities. So, can you just elaborate how the dantrolene preparation is done at the site or when you are treating the MH case?
We'll take a sterile container
Yes.
with plenty of distilled water, and we'll add the vials. We'll open the vials directly and empty in the container in plenty of sterile water. We can give a stat dose of 1 mg per kg. So like we can take 4 vials, which will be about 80 mg for a 70 kg patient, and we can empty in plenty of sterile water and administer.
Yes.
What are the MH susceptible patients, and what will be your plan in case of such MS susceptible patients?
So MH susceptible patients, they are patients if we find a history, if the patient is giving a history that there is unexplained anesthesia related deaths in the family, or there is history of exposure to general anesthesia where the triggering agents were given, even if it was uneventful, or if a patient has a relative who is a known case of malignant hyperthermia who has elevated creatine kinase levels, that patient will also be considered as malignant hyperthermia susceptible, even if the contracture tests are not done. So if we are posting such a patient for a surgery, first we will avoid the triggering factors. We'll avoid use of volatile agents and scoline. We can do the surgery in total intravenous anesthesia, propofol, etomidate, benzodiazepines, opioids, barbiturates, non-depolarizing muscle relaxants, and even regional anesthesia if possible. We'll make provisions for monitoring the patient, the core body temperature, ETCO2. We'll try to avoid exposure to any volatile agent. So we will flush the anesthesia machine with high flow of oxygen, about 10 ml per minute, 10 liters per minute for at least 20 minutes. Then, if possible, we will detach the volatile agent. If not possible, we can apply a tape to the volatile vaporizer canister. We will change the CO2 absorber and put a fresh absorber. We can also use activated charcoal filters to accelerate the cleansing process. Then, if possible, we'll arrange for dantrolene if it can be made available. We will make provisions for post-operative ICU management of the patient. ICU bed has to be reserved.
Yes. So suppose you get a patient who gives you history that he has a history of some sudden death during exposure to any previous anesthesia or surgery. So in that case, you can keep the possibility that this patient can be of malignant hyperthermia. So in such suspect patients, you can get the things ready beforehand only, anticipating the grave MH incidence. So what is malignant hyperthermia kit?
So, as with anesthesia, everything is about preparedness and anticipation. So malignant hyperthermia kit is basically a storage unit where we are keeping everything ready in case we encounter a case of malignant hyperthermia. So in this kit, the first thing would be dantrolene. We have to, as discussed previously, we have to keep a minimum of 8 ampules if you are using Rivalto or Dantrium, the brand, or if we are using Rhinodex, then we have to keep a minimum of 4 vials ready. Then we have to keep the sterile water bags that we are going to use. We have to keep calcium gluconate and then lignocaine, drugs used for ACLS for resuscitation, CPCR drugs. Then there are other paraphernalia like core body temperature probes. Then we have to keep the charcoal filters ready if we need to use for such a patient. Then the CVC lines for all age groups we need to store that might be needed for these patients, the transducers and the pressure bags that might be needed. Mainly that we have to keep the drug ready.
So here again, I would like to point out that especially the teenage group and that too males or boys in this age group are more susceptible or more to be taken suspicion that they can be of risk of malignant hyperthermia or myopathies or muscle diseases. That is likewise we can always consider, especially when they come with some genetic diseases problem, like some abnormal muscle surgeries like scoliosis, like strabismus. So these are particular age group and particular surgeries. and which are coming with some genetic problem or with history of consanguineous marriage or positive family history of anesthesia related deaths. So in those cases, always we should have a suspicion of MH, and it is always better whenever possible, it is restrict the use of succinylcholine for such young patients where you don't anticipate any difficulty in intubation. So that will be a safer side. Again, hope to go with succinylcholine free intubation and use of TIVA. Okay.
Yeah, this is now we have covered the case discussion in a whole and pathogenesis of the malignant hyperthermia. What are the presentation? What are the differential diagnosis for malignant hyperthermia? What is the drug of choice? Diagnostic test for malignant hyperthermia. But internationally, there is one scoring system to predict that malignant hyperthermia. So, can you elaborate the clinical grading scoring system for malignant hyperthermia?
Sir, so Larash and others had done a study where they found
Manogya.
out that there are
Manogya,
yes, ma'am.
please explain it slowly. Don't
Yes,
go
ma'am.
so fast.
Yes, ma'am. Larash and
You
others
can
had
share the
done.
slide also.
Yes, yes, sir, it's ready. So though they had done a study where they found that only some factors are more important than the other factors in determining if the patient had malignant hyperthermia clinically. And therefore, they had done a scoring system where the score of more than 50 was considered to be confirmatory for malignant hyperthermia, irrespective of the contracture testing or the muscle biopsy testing. So we'll have a look at the testing. So there are 5 processes here. The process one is of muscle rigidity, and they have given appropriate scoring for generalized rigidity or only localized to masseter muscle. The process 2 is myonecrosis. So myonecrosis is indicated by elevated creatine kinase levels. So higher elevation of more than 20,000 has been given a higher score, and then myoglobin in the urine more than 60 was given a score of 5. Like this, the process 3 is of respiratory acidosis, where the ETCO2 more than 55 and PaCO2 more than 60 has been respectively scored. Process 4 is for temperature increase, and process 5 is for cardiac involvement and the presence or absence of dysrhythmias. The other criteria include arterial base excess and arterial pH. Apart from this, for MH susceptible patients, there is a family history which has been added to the score and in determining the score of those patients.
Okay. So this was up till now the case discussion, and Manogya, now we will proceed with our MCQs for this topic. So can
Yes.
you go with one by one?
Yes, ma'am.
So all please note that we will be showing you the MCQs and you can give the answers in chat box. Yes, chat box is open. Yes, yes. We are getting the answers of our first MCQ, and they are right.
So the correct answer is masseter
Yes.
spasm.
Yes. So now we'll proceed with our second MCQ on malignant hyperthermia. So I can see many people answering rightly. It is succinylcholine, which is a known triggering agent for malignant hyperthermia. Right. So let us proceed for third MCQ. What rate of core temperature change is required to make a diagnosis of malignant hyperthermia? Yes, I can see the right answers. It is increase of 1 degree Celsius every 5 minutes. Good. So here is MCQ number 4. What is the site for muscle biopsy when we take it for a malignant hyperthermia case? Yes, many students are responding, and the right answer is vastus group of muscles. So here is our fifth MCQ. What is the loading dose of dantrolene sodium in case of malignant hyperthermia? So the loading dose, the books have mentioned 2 to 2.5 milligram per kg IV, right? But we can proceed with 1 to 2 milligram per kg IV also. And then as per the need or as the condition subsides, then the dose can be subsided. So, and it should be continued till the whole picture is settled. So maximum dose can be given up to 10 milligram per kg. So according to the availability of dantrolene has to be there. So usually we keep 4 vials ready in malignant hyperthermia kit as a minimum first dose. Yes. So this part is over now regarding multiple choice questions and the case presentation of malignant hyperthermia. So now I would like to request Dr. Vivek, our resident, to present his topic of temperature regulation and temperature monitoring. Vivek, please.
Yes, ma'am. Good evening, everyone. Myself,
Just a
Dr.
minute.
Vivek Baghel, junior resident. I will be talking on the topic thermoregulation and temperature monitoring. So we know that humans.
Just a minute. We see one question here. What's the end point of dantrolene infusion? So as we have just now mentioned, you can start with the dose of 1 to 2 milligram per kg. For a 60 kg patient, say it around 80 milligrams or 4 vials. And then after that, it should be continued half an hourly with the further maintenance dose. 0.5 to 1 milligram per kg till the symptoms subside. Patient has to be admitted and observed continuously, because sometimes even the relapse of the malignant hyperthermia can occur within next 24 hours. So it is always better to be ready if it does occur in near next 24 hours, and be ready accordingly along with dantrolene and other cooling measures and everything as we have mentioned here. Okay, Vivek, please start.
Yes. Okay.
You can go ahead, Vivek.
Is my screen seen?
No.
Excuse me, ma'am. Little louder, ma'am. The presenter asked.
Okay, Vivek,
Okay.
you be louder and slowly you can go ahead.
Okay, ma'am.
Don't be too
We'll start with the topic thermoregulation and temperature monitoring. So
Your
we
screen
know
is
that
not visible.
Green.
humans, they are endothermic homeotherms. That is,
Vivek,
we are.
Vivek, excuse me. Screen you can share of your presentation.
That MCQ slide we have seen.
Yeah.
Go ahead with your screen sharing. Yes,
Yeah.
yes, it is there.
Temperature regulation and temperature monitoring. So we know that humans are endothermic homeotherms. That is, they are warm-blooded animals who maintain a constant body temperature irrespective of the environmental temperature. Body temperature, it is determined by relationship between heat production and heat dissipation. The normal human body temperature, it is 36.5 to 37.5 degrees Celsius, and it undergoes circadian fluctuations, being the lowest in the morning and highest in the evening. And this normal body temperature, it is important to maintain the enzymatic activity and other metabolic functions. Extremes of ages, sepsis, burns, trauma, endocrine abnormalities, malnutrition, they predispose patients to risk of hypothermia. There are two types of body temperature. There is core body temperature and surface temperature. Core temperature, it is temperature of the deep tissues of the body. It remains relatively constant unless exposed to extreme environmental changes, and it is assessed by using a thermometer. Surface temperature, it is temperature of the skin, subcutaneous tissue, upper and lower extremities. It may vary in response to the environment, and it can be assessed by touch or even skin pads. When we talk about heat loss from the body, it occurs by 4 mechanisms. The first mechanism is radiation. So a body will emit heat in the form of infrared radiations. This is the major mechanism for heat loss in human beings, as we can see in the first image. The second image, it shows conduction. So it is heat loss by direct contact, that is from core temperature to the adjacent tissues. Third is convection, which is heat transfer by air currents. It is the second most common mechanism. It is transfer of heat from core body to the peripheral body temperature, to the periphery. And evaporation, it is loss in the form of water vapor. It is loss from intact skin, mucosa, and exposed surgical sites. So when we talk about radiation, the patients in the operating room are usually unclothed. This leads to significant radiation loss in the form of radiation. This can be countered by either heating the surrounding surface, like in infant incubators or forced air warmers, or we can counter it by applying blankets, which will absorb and return the radiant heat back to the patient. Conduction, the loss of heat from body occurs by direct contact with a cooler object. For example, patient and cold air, or patient and an adjacent cold mattress. This conductive loss to still air is limited because a stationary layer of air next to the skin acts as a good insulator. For example, in humans, piloerection reduces the heat loss by trapping a layer of air next to the skin. Also, in OT, when you apply surgical drapes, cotton blanket, or plastic cover, it will form a layer of still air and decrease conduction. If this conduction is facilitated by air movement, it is called as convection or facilitated conduction. Example is forced air warmers, where the patient is lying and we apply a forced air warmer. There is a warm blanket which circulates warm air around the patient. So this will cause reverse convection. That is, the heat will be gained by the patient from the warmers into the core body temperature. And evaporation, loss in the form of water vapor, it is significant in surgeries with large segment, where the large segment of bowel is exposed. So temperature regulation physiology, there are 3 parameters. There is afferent impulse, central control, and efferent response. Afferent impulse it is carried by the warm fibers, that is the unmyelinated C fibers, cold by A delta fibers, and these are carried by the anterior spinothalamic tract. There is central control in the form of behavioral response. That is, if you're feeling cold, you put on a jacket, or you observe a curled posture. Or autonomic response, which is carried by the hypothalamus. It compensates in the form of either vasodilatation or sweating if the temperature is hot, and vasoconstriction, shivering, piloerection if the temperature is cold. There is also something which is non-shivering thermogenesis. It is seen in infants who have increased brown adipose tissues, which on exposure to cold releases catecholamines and causes increased production of heat without muscular activity. So there is a term which is interthreshold range. It is that range over which the autonomic response to temperature is not activated. That is, if we consider this range, that 36.7 to 37.1, this is the narrow range. If my temperature, body temperature goes above 37.1, sweating threshold will be, that will be crossing the sweating threshold. So my body will start sweating. If it goes below 36.7, there'll be vasoconstriction. In between 36.7 and 37.1, there'll be no response. And this no response is very narrow. It is 0.3 in normal patients. But when we give anesthetic agents to the patients, there is impairment of this autonomic response. And the threshold for sweating goes up and the threshold for shivering goes down. And the gap in between, where the patient will not respond to changes in temperature, increases. And it increases by 10-fold from 0.3 to 3 degrees Celsius. So if you look at this diagram, the blue line is the sweating threshold. The green line is the shivering threshold. In between this, the patient will not respond to changes in the temperature. So when I'm giving desflurane, there is this from 32 to 38, the patient will not respond. So there will be loss of autonomic response. So similarly, other anesthetic agents also increase this interthreshold gap. So when we talk about thermoregulation and general anesthesia, in general anesthesia, all the three elements, that is afferent, central control and efferent, all three are abolished. Behavioral regulation cannot take place. Autonomic regulation is impaired. As we discussed, the interthreshold range increases. The drugs will cause vasodilatation and muscle relaxation. So they cannot be compensatory vasoconstriction in response to hypothermia. And the patients become poikilothermic, that is cold-blooded within this range when they are receiving general anesthesia. So we can see this diagram. The core temperature is 37 degrees Celsius. Whenever we give general anesthesia, there is heat redistribution from core to the periphery, and the core body temperature decreases. When we talk about spinal anesthesia, the brain may interpret it as warm legs. That is, due to peripheral vasodilatation, the patient may appear warm. Also, the compensatory vasoconstriction will be inhibited in the blocked areas. Therefore, hypothermia may go undetected intra-op and may be detected in the post-anesthesia care unit. But when we compare spinal and general anesthesia, in spinal anesthesia, vasodilatation occurs only below the abdomen, in only a part of the abdomen, part of the body. Whereas in general anesthesia, overall vasodilatation occurs. So when we compare the two, we see that patients recover from hypothermia faster after spinal anesthesia as compared to general anesthesia. We can see the warming time, it is more in general, less in spinal. Patients given spinal anesthesia rewarm more quickly to the core body temperature than those given general anesthesia. So we can see intra-op, the body temperature decreases, and for spinal patients, they come back to the normal temperature faster than patients who underwent general anesthesia. So when we talk about hypothermia, it is a decrease in the body temperature less than 36 degrees Celsius. It is classified into mild, moderate, severe, 32 to 35, 28 to 32, and less than 28 is severe hypothermia. If we do not treat this hypothermia, the natural progression of untreated hypothermia is as follows. There will be phase 1, where the body temperature will rapidly decrease. So there is a rapid fall, followed by a linear fall, followed by a plateau. Rapid fall occurs because it is the initial in the first 1 hour of the surgery. So it occurs because of the radiation redistribution from core to the periphery. In phase 2, it is linear. So body tries to generate heat, but the loss of heat is more than the generation. So there will still be a fall in the temperature. And phase 3, where the body tries to compensate and it successfully compensates, and there will be a plateau phase. This occurs after 3 hours usually. So if we talk about the deleterious effects of hypothermia, it is as follows. There will be increased risk of operative blood loss. Because of hypothermia, there is stasis of blood. There will be coagulopathy. The platelet adhesion, platelet aggregation decreases. Von Willebrand factor, it decreases. Its function decreases. So there will be increased blood loss, risk of blood loss. There is increased morbid cardiac events because of peripheral vasoconstriction. Blood volume will go back to the center, and there will be increase in the myocardial workload, leading to morbid cardiac events in patients who are susceptible. There is increased sympathetic activity, which can cause dysrhythmias. There will be risk of wound infection and delayed wound healing because of sympathetic cutaneous vasoconstriction. Also, there is decreased drug metabolism, increased volatile agent solubility, and decreased minimal alveolar concentration of the drugs, which causes delayed anesthetic emergence. And there will be delay in the recovery group discharge because of post-op shivering and delayed recovery. So when we talk about factors that decrease the body temperature during surgery, as we discussed, resetting of the hypothalamic thermostat, that is increase in the interthreshold range, ambient temperature. If the OT temperature is below 21 degrees Celsius, there is risk of hypothermia. So it is suggested that the OT temperature should be at least 21 degrees, more than 21 degrees Celsius. Administration of unwarmed intravenous fluids, drug-induced vasodilatation, decreased metabolic rate, decreased shivering response. The core compartment is exposed to the ambient temperature, and heat required to humidify the inhaled dry gases. These all factors will contribute to hypothermia during surgery in a patient. There are also benefits of hypothermia which are used in neurosurgery because it decreases the cerebral metabolic rate. It is cerebroprotective. It decreases the oxygen consumption, decreases free radicals. So it is used in neurosurgery. So when we talk about temperature monitoring, as we discussed in the diagram, initially there is very much fluctuations in the blood temperature. So in the first 30 minutes, the changes in the temperature is difficult to interpret. So it is advised that only cases that exceed 30 minutes should undergo temperature monitoring. So temperature monitoring is done only in cases which exceed 30 minutes. It is also recommended that intra-op core temperature has to be maintained above 36 degrees Celsius. So when you have to monitor the core body temperature, we can use the following devices. The gold standard is pulmonary artery. We can use a pulmonary artery catheter. It has thermistors. It will detect the core body temperature, but it is invasive. So the best site to detect is distal esophagus. It is a non-invasive thing. So we can use a esophageal stethoscope, and at the point of maximal heart sound, we'll measure the temperature. We can use a nasopharyngeal probe. It is placed behind the soft palate. It is less reliable. Tympanic membrane can be used. It is semi-invasive, but it is rarely used because patient is under general anesthesia, and we do not know the depth. We might injure the tympanic membrane. Rectal temperature can be used, but it has intermediate efficacy because it is influenced by heat produced produced by the bacteria in the gut, cold blood returning from the lower limbs, and insulation of probe by feces. Also, during cardiac surgeries, bladder temperature is used. It is of intermediate efficacy, as good as a rectal temperature when the urine flow is low. But if the urine flow is high, it is as good as core temperature, that is pulmonary artery temperature. Axillary temperature can be used if it will be accurate if you place the probe at the axillary artery and the arms are tucked. Also, infrared rays are used, but it is less accurate. Infrared external auditory canal and infrared temporal artery measurement. So the gold standard is pulmonary artery, and the best site is distal esophagus. Prevention of intraoperative hypothermia. So we can use warm patient mattresses, forced air warmers. It currently offers the best combination of high efficacy, low cost, and remarkable safety. We can use warm IV fluids, adequately drape the patient with no exposed skin, use of warm fluids for surgical irrigation, heat humidification of inspired gases, and operating room ambient temperature at least 21 degrees Celsius. So the warming methods we can use, one is intravenous fluid warmers. We can use insulated intravenous tubings. A water bath can be used where we can put in the plastic fluids to warm the patient, and we can use convective warming systems. Secondly, we can do cutaneous heating in passive and active form. Passive form is when we apply a single layer of any passive insulator, say a surgical drape or cotton blanket or a plastic cover over the patient. This will not it will not provide any insulation, but it forms a still layer of air between the skin and the patient's skin and the atmosphere, the environment. So it decreases the conduction. Also, actively we can heat the patient in the form of following. We can use circulating water mattresses. There is circulation in the mattress, so its target organ is the back, but back is relatively small, so small fraction of total body surface area, so it is less accurate. Forced air warmers, it consists of an electrically powered heater blower system. So it has two mechanisms. There'll be flow of warm air around the patient, so there'll be decreased radiation because the cool surface outside the patient is replaced by warm air, so it will decrease the radiation. Also, it will increase the convection. Warm air which moves rapidly over the skin causes heat from the warm air to the patient. Resistive heating, it's an electronic device, electronic blanket which can be used. Radiant warmer, it has special bulbs which emit infrared rays which help in radiation to the patient from surface, from external to the core temperature of the patient. There can be use of negative pressure warmer. It consists of a vacuum which is applied to the arm and the forearm of the patient, and it pushes heat from periphery to the core. And hot water containers. We can place hot water containers at places where there is increased blood flow, like axilla, to decrease the temperature of the patient. This is a forced air warmer. There is this device, and there's a tubing, and this is the warming blanket. It supplies warm air to the patient. This was intra-op. So post-operatively also, we have to continue forced air warming in patients who are susceptible to hypothermia, and continue the use of warm intravenous fluids. Pharmacological treatments for forced anesthesia shivering, we can use tramadol, dexamethasone, clonidine, dexmedetomidine, and elfentanil. Also, other drugs like the study here, it shows that induction of anesthesia with ketamine reduces redistribution hypothermia. As we know, ketamine causes vasoconstriction, so it will cause decrease redistribution of heat from core to the periphery. Also, another study showed that preoperative midazolam may also reduce the hypothermia by occurring during general anesthesia when the sedation depth is moderate. ASA standards, American Society of Anesthesia, has given basic anesthesia monitorings, standards for basic anesthesia monitoring. One of them is body temperature. So even they have suggested that we have to monitor the body temperature of the patient. There is NICE guidelines, National Institute for Health and Clinical Excellence. They had published an article for inadvertent perioperative hypothermia. They have given the following guidelines. Special care should be taken to keep the patients comfortably warm when they are given pre-medications. In the operating theater, the ambient temperature should be at least 21 degrees Celsius, at least when the patient is exposed. Once forced air warming is established, the ambient temperature may be reduced further to allow better working conditions. The patient's temperature should be measured and documented before induction of anesthesia and every 30 minutes until the end of surgery. Induction of anesthesia should not begin unless the patient's temperature is at least 36 degrees Celsius. This is the end of my presentation, ma'am.
Okay, so thank you, Vivek, for excellent presentation.
Thank you, ma'am.
So I can see one question here. How do we warm the patient for laparotomy when they have opened up the cavity and these mattresses can't be used liberally?
We can use, like if they are using, we can use warm fluid for irrigation, surgical irrigation.
Yes.
And we can prevent conduction by at least draping the patient by using surgical drapes or blankets.
Yes. Very
Also,
simple.
the intravenous fluids that we can give warm intravenous fluids.
Yes.
And the patient, we can place warm water containers at the site of increased blood flow, like axilla.
Yes. So simple measures like dripping in.
Apart from that, commercially there are available segmental forced air warmer blankets. So they just cover the upper limb and the upper thorax. The segmental forms are still available rather than the full body ones also. So if they are accessible to those products, then they can use them. If not, then as he has mentioned.
Yes. So temperature monitoring during general anesthesia, regional anesthesia is equally important, though it has been mentioned as a part of standard monitoring, but bit neglected monitoring. So we should henceforth take care of monitoring our all patients, especially in those surgeries which are lasting for more than 30 minutes. And the simple measures we can go ahead with whatever is available at least, and like draping surgical drapes or in 2 layers, that also can be a simple measure to preserve heat and to prevent heat loss. Then warming IV fluids to prevent hypothermia. Then heating blankets, we can demand them for our institutes and can keep them ready. And here I would like to mention especially about neonates and extremes of age, like old age patients. In both these types of patients, we should always be ready to anticipate the proper temperature being maintained, and we should be ready accordingly. Neonates, because of their larger surface area, they can be prevented, heat loss can be prevented by covering them adequately. Then elderly patients, they are, as we know, they have the decreased capacity to maintain thermoregulation physiologically. So they are also should be considered when we are going for temperature monitoring. So I can see here a question, can we pre-warm IV fluids in warm bath? So as per our requirement and OT temperature, we can very go ahead with by pre-warming the IV fluids, but always be cautious, they are not getting extra heated. The warmth should be adequate as per our body temperature.
So one more point I like to add, as we can say that pre-warming of the IV fluids, just like that, you can pre-warming of the patient can also be done before the taking patient to the operation room. that should be done 30 minutes prior to the actual operation time. And if we can achieve by simple measures, you can have warm IV fluids, you can have forced air warming, you can have warm water blankets, and by these methods you can pre-warm the patient before taking to the operation theater, and this will definitely reduce the chances of hypothermia in case of longer duration surgeries and extremes of age patients.
Yes. I can see the question of ideal method of warming IV fluids. Warming or fluids warm, how to warm IV fluids. So fluid warmers can be the one option. Then adjusting our OT temperatures as per the need.
Yeah, I would like to add some points for
Yes.
warming IV fluids. There is no such ideal method to warm the IV fluid. Just we can keep them in a warm water also, warm water bath. There are some instruments, means tubing heaters, from which we can pass the IV tubing, which can heat the internal IV fluid. Okay, but these are also, there are also practical difficulties in that case. It will depend that at how much fast we are administering the IV fluid. As if we are administering the IV fluid fast, then there is possibility that warm IV fluid can go to the patient. But if we are administering that IV fluid, warm IV fluid slowly, that fluid will again get reduced temperature before reaching to the patient level. But there are only 2 to 3 methods only, that pre-warming of IV fluid and passing the tubing through machine, means heated machine.
Also, there should be careful use of electric heaters and warmers. There should not be occurrence of any accidental burning. I can see a question. Can we warm the blood? Yes, somebody is asking. So, the simple common sense that we should not infuse blood as it arrives so that cold. So it should be kept like that. Let it come to at least OT temperature or a subside. Temperature should be adequate, and then you should start with blood, or you can here also you can use fluid warmer.
Yeah, ma'am, one more thing, shall I add to it?
Yes, sir.
Yeah. So it depends also on the urgency of the situation also.
Yes.
If you really require it that fast, but I don't think so. We give just blood for the maintenance of hemodynamics, something like that. It's basically the oxygen carrying capacity. And it's always advisable whenever the blood unit comes from the blood bank, just keep it for half an hour at the ambient temperature of the operation theater. At almost a room temperature, you can say, just half an hour. After keeping, just infuse that blood. These are the recommendation now, because I've been into the committee of these transfusion requirements also there in the college. So we are almost getting these type of advisories regularly, every 3 monthly to 6 monthly. So whatever you call the ambient surface in the operation theater, that is good enough.
Yes. So let us start with the MCQs on this topic. So we take the first MCQ. First MCQ is, what is the gold standard for measurement of body temperature? Site. So you can see the answers as pulmonary artery, but even though it's a gold standard, the most economical safe is distal esophagus. Yes. The next MCQ is ambient temperature of at least Yes, right. It's 21 degrees Celsius. All have rightly replied. Said. What are the afferent impulses? What are the fibers which carry afferent impulses of temperature? Yes. Answer is A delta fibers. Right. Next, MCQ. What is the major mechanism of heat loss in humans? Yes. Right. It is radiation. Fifth is, according to NICE guidelines, induction of anesthesia should not begin unless the patient's temperature is 32, 34, 36, 37. All have rightly answered. It is 36 degrees Celsius or above. So thank you all. May I ask for questions?
All the questions in the chat box have been answered, ma'am, till now.
So the take-home message here is, though rare, occurrence of such case like malignant hyperthermia unexpectedly on operation table can be a very much devastating management or time for the anesthetist to manage. So it is no doubt it's a teamwork, and always it is better to anticipate the things, but every time it is not possible. In every case, we may not go with temperature monitoring with all ideal scenarios. So we should always be vigilant and should keep a suspicion in any case like, as I mentioned, teenage boys and with any family history of unanticipated, unexpected death in the past. And in our scenario, people are not very aware. There is least awareness about such history, and even the reporting of cases is also very much less, as it has seen only 8 cases of confirmed malignant hyperthermia have been reported. And because of the restrictions of muscle test, muscle biopsy testing, genetic testing, we are so much behind. So it's what at the most what we can do, always go for safer options when you suspect such scenarios where some abnormal, especially in young age groups. So in those cases, what we can do, that we can avoid the triggering agents. And it's not that master muscle spasm will occur only with malignant hyperthermia. It can be the first presenting symptom for other muscle diseases conditions also, like myotonia, then myopathies. So we should always get alarmed, we should get warm when we come across such muscle spasm, muscle rigidity at the induction of anesthesia. And we should postpone the case if possible, and if it is an elective surgery. But if it is an emergency surgery, always it is better to treat and then go for, once patient is settled, then go for other options to avoid the triggering agents and go for safer anesthesia.
There's a question, ma'am, in the chat box. How much duration of induced hypothermia is safe in neuro ICU and for neurosurgery?
It depends, actually, we can't report the exact timing here. But we can maintain the temperature in the safest possible zone and better be vigilant that it should not fall down below 30, below 20, it is most hazardous. So better maintain it in safe range.
Okay, ma'am. All the questions have been answered, ma'am.
Yes.
Ma'am, Madhuri, ma'am.
Yeah,
Yeah.
you
can
have
you
very
please-
good presentation, ma'am.
Thank
This
you.
topic actually is very important. This is for the sake of the PGs, that this is very important, that it all very often comes as a theory question, isn't it? That you discuss the methods of temperature control, the physiology of temperature regulation. That is from the theory paper point of view. And practically, of course, since nowadays we have modular OTs, it is very important that the patient often gets cold and we have to do the temperature monitoring. And as Bajwa sir has already told about the so many cases of malignant hyperthermia coming up, clinically it is very important to measure the body temperature. So now this question is for the postgraduates, that see, whenever there is a stimulus, for example, an increase in the body temperature, what are the sensors? Who senses this increase in body temperature? And what is the control center in the brain?
Preoptic anterior hypothalamus.
No. First, let us start from the periphery. So, which are the sensors? This is, we are going to the physiology of temperature control and regulation. So,
The unmyelinated C fibers and the
yes.
Yes, ma'am. Unmyelinated.
So, you have told this in your
Unmyelinated.
presentation.
Yes, ma'am.
What are they? The
Unmyelinated C fibers, they carry the warm stimulus, and the A delta fibers, they carry cold stimulus.
Okay, so that means they are the peripheral and central thermoreceptors, you
Yes,
mean to say, right?
Yes,
Now,
yes,
what is the control center in the brain?
it is related in the hypothalamus, ma'am.
Hypothalamus.
Anterior and posterior hypothalamus.
Anterior and posterior
The posterior
hypothalamus.
hypothalamus, it will respond to hot environment, and the anterior hypothalamus, it will respond to cold environment.
Very good. So that's the basic. Now, what about the effectors? Which are the effectors?
Peripheral muscles, ma'am, in the form of peripheral vessels. Peripheral muscles.
Vessels, huh? The blood
the
vessels
fat
in
adipose
the
tissue.
skin.
Yes, ma'am.
Skin
Cutaneous.
blood vessels, which
Yes,
includes both arteriolar and arteriovenous anastomosis.
Yes, ma'am.
Okay, next, any other effector?
Ma'am, adipose tissue
If it is increase in temperature, means the sweat glands.
Yes, ma'am.
Then anything else? You were talking of adipose tissue.
Piloerection, ma'am. Piloerection.
No, wait, don't run. Yeah. Piloerection. Piloerection is, the erector pili muscles.
Yes, ma'am.
You mean to say.
Yes, ma'am.
Okay, that is for cold response.
Cold, yes, ma'am.
Response to cold. Then what about you were telling something about adipose tissue, no?
Yes, ma'am. The brown adipose tissues, which are abundant in infants, they respond to
What about in adults? How much of adipose tissue do you have, brown adipose?
In adults, it is present in the supraclavicular region, in the paravertebral region, whereas in infants, it is present in the interscapular region.
Yes.
It
So
is
that
less active in adults, ma'am.
yes, and adipose tissue, it produces heat Non-shivering thermogenesis.
Yes, ma'am. There is no
Right?
muscular activity, but production
Yeah.
of heat.
And what about the endocrine glands? You did not mention about the endocrine glands.
Yes, ma'am.
Which endocrine glands?
Catecholamines will be released by the adrenal glands.
Very good. Yes.
Yes, ma'am.
And the thyroid gland also. Thyroid gland also.
Yes, ma'am.
So if it is a decrease in temperature, what happens? The metabolic rate, what will be the response?
Decreases, ma'am.
Are you sure?
Yes, ma'am.
If it is an increase, the response will be what? It will be
Ma'am, hypothermia causes decreased metabolism.
metabolic
Decrease,
rate.
yes, ma'am. So decreased response in hypothermia.
Yeah. And what about the changes in behavior?
Ma'am, behavioral changes, they are controlled by the central system. So like wearing a jacket or assuming a curled posture.
Yeah.
Or going to a different place where there is
correct.
warmth.
So body position, for example,
Yes, ma'am.
Yeah, body position and the activity, the level of activity, that is also affected. So this is the how it goes, the cycle of thermoregulation.
Good. So, Madam Nilambri has prepared the PG students very well. They are full of confidence, answering in a good manner. But confidence is required. This is the basic vision of these classes. The PG student should be able to answer any query, whatever been asked from the toughest of the examiners or from the audience. Maybe a weird also, but I think the way you are answering is a good preparation. I think that has gone for the hard work put in by the professor and head madam. So she has prepared you well, along with Dr. Sachin and all the consultant in the departments. So considering that, first of all, it's a time to felicitate also. But before that, any other question is there? Just try to cover that. If any question is there.
One question was asked, sir, regarding the safe duration of induced hypothermia in neuro ICU.
Yeah, and it was asked actually. At that time, my net just went off because I think that question was there. How long it should be safe? Now that's a very tricky question. If you ask me, if you go clinically for any neurosurgery, see the neurosurgeries are usually long procedures. You can't say a definite time that this much of the hypothermia is, safe and optimal and recommended. There are many guidelines also on different durations of keeping hypothermia. It also depends upon your type of surgery, the patients, the hemodynamic fluctuations during this one. Surgeries also, there are so many factors to be considered. And these factors always decide the duration. Duration means if you say that I want to keep it for 3 hours, you can't give it in a writing that 3 hours is a safe period or 3 hours is a difficult period to keep it or it's not a risky period. So it also depends upon the surgery, the age of the patients, the pre-operative status of the patient. ASA1 may tolerate the things better as compared to the ASA3 and ASA4. Then upon the duration of surgery, the hemodynamic parameters, fluctuations, and there are so many other factors also. It's a very tricky question. It cannot be answered.
Articles are mentioned, sir. It is up to safe up to 24 hours.
So that you can keep trying anything, but more important after this is if you want to bring that patient back to the normothermia, that process is more important. How you take it, because that process has to be very gradual. The more rigorous, the more aggressive you become to bringing the patient to a normothermia, that can almost, cause a much higher morbidity and mortality in these patients. The more the duration of the hypothermia, is the more difficult to bring back the patient to normothermia in the shortest period. It has to be a very gradual process. Actually.
Yes.
So I'm telling you, this is a very patient specific now. I think many guidelines will be coming now. Somebody saying geriatric patients, how much the normothermia or hypothermia you can keep, and at what temperature also.
Yes.
That also the degree of temperature, at what degree you want to keep hypothermia. So many things are there. I think the literature is full of so many articles. Some you will get some contradictory also remarks also. Somewhere you get a good guidelines also. There were so many things, very difficult to define I'm still able to now to answer this question. 24 hours or even 48 hours, then why 48 hours is not good? If 24 hours is good, ma'am. If we are keeping the hypothermia, there are so many reports, anecdotal reports are there where I've kept a temperature for a long period in ICU just to prevent the morbidity and mortality. So very difficult for me also to answer exactly. It depends upon individual patient,
Yes.
your particular surgery, the duration of surgery, the magnitude of the hemodynamic fluctuations. So many things are to be considered here. And every time we need the evaluation of our existing guidelines also to go further about it. Because once we give a statement, a blanket statement, that is going to do more harm than good. Because those will be taken as a gospel by the societies, by the higher of the societies, and that will be taken as a gospel and medically also not safe, as well as clinically. Anybody has else to suggest about this particular thing? A solid thing regarding the duration of hypothermia. It's not neurosurgery. I think any type of, even in the cardiac also, we require hypothermia for a long time. Sometimes. Yeah. Surekha madam is answering something. Anybody, ma'am? I think everybody can raise their hands and unmute themselves.
Hello.
Yeah.
Hello. Sir, in neuro ICU,
बोलिए sir, बोलिए.
these cases, they try for 24 hours maximum, I think. So
That's why, sir, I say if 24 hours is safe, why not 48 hours also safe? That is my question actually.
usual practice, they try for 1 day, have to induce hypothermia in neuro cases to prevent the CNS damage in arrest cases or post cardiac arrest
Because, sir,
cases.
that they keep just to bring that for a normal protocol for bringing the patient back to the normal, you can say, status to for other weaning processes also. So they keep it like that. But that's why I'm saying if 24 hours is say, why not 40 hours? Because these type of things are not, practiced as a routine investigation, routines, clinical studies also. The clinical trials are also lacking because these types at some stage we cross that ethical and clinical limits of putting these patients for that rigorous studies. So that is the problem with these type of studies, sir.
Yeah. Okay.
So thank you, Bajwa sir, Surdi madam, Durga, Swati, and whole team for giving us this valuable opportunity to present our case and PPT presentation here on this wide platform and prestigious platform, sir. Thank you very much.
Yeah, ma'am, that's why we also want a small appreciation from ISA
you,
national side.
Thank you, sir.
For presenting this class, especially you, ma'am, preparing your team very well. So we are thankful, and you've done a wonderful job today. The presentation was very simple and fabulous. That was more important. And the PG students were very much well prepared and confident also. The confidence is the hallmark of these classes. If they're confident, that means the knowledge, they are completely filled with knowledge, practical as well as theoretical, ma'am. So thank you, ma'am, for being a faculty for this class.
Thank you, sir.
And Dr. Sachin also. Sachin, I know the next deputies are always working very hard in preparing to the PGs because they are more associated with them, closely associated with them. So Dr. Sachin, thank you very much for being teacher in this class. And Vivek, as well as Manogna, both did a wonderful job. I'm proud of you that you have done a good job and kept the name of your institution flying high in this class. You almost answered everything. And Swati, Dr. Swati, thank you for being the class coordinator, screen coordinator for this class, and Dr. Devi Durga also. So both are also, these are the people who do the technical, the correctness of these classes. So thank you very much to Dr. Swati and Dr. Durga. And thank you to Dr. Madhuri, Dr. Idima, Dr. Nishant, because they are the real class coordinator, the back force for these classes. This is how our classes are going. And then the results of the classes are seen from the way the PGs are participating in answering. And in the YouTubes also, we see there's so many likes and dislikes. So I think that one more, Dr. Sadikur Rahman has given a very good explanation. You can go through, Dr. Swati can read it.
Yes, sir. Most patients can tolerate 30 minutes of DHCA without significant neurological dysfunction or adverse effects. However, longer periods of DHCA, 40 minutes or more, may increase the risk of brain injury. Deep hypothermic circulatory arrest, just 24 hours to 48 hours, is not significant. Hypothermia for 48 hours to 14 days in neuro ICU, it is significant in decreasing cerebral edema and ICP.
Yeah, I think the same way, but we were discussing. So these things are there. And Dr. Surekha ma'am has given a very good thing. Team ISA and Bappa Moria. That's the best way. The festival on in the biggest land of Maharashtra. There is a maximum, I think, celebrations are in that land. So it's and good also that Dr. Lamri Atke and team had come in during this festive period to do the class. That's a very remarkable. Thank you, madam, for being here. Last 2-3 minutes, anybody want to suggest or give a suggestion, they can unmute themselves and can give, or they can comment. Anybody? I think almost everybody is well understood today, well read today. No more further queries. Dr. Madhuri, I think she wants to say goodbye.
No, I don't want to say any question. I was just thinking that temperature is a vital sign, right? But yet, in the monitoring, it's never not mandatory monitoring.
No, actually, if you see the type of things now happening, the type of surgeries we are encountering, the type of patients we are encountering, especially in the specialized centers, I think temperature monitoring is a must for every patient in these type of cases. What I am less, skeptical is the peripheries. We don't have those type of monitors. We may have some nasal probe. We may have a middle ear probe also for temperature monitoring. The esophageal stethoscopes and temperature probes are there. So many things are there, but ideally it has never been given that much importance. But where I think the temperature monitor is very essential when we are going for a little hypothermia or even for a temperature rise, because the vigil is very important nowadays. Anything right? I think even if the surgery has not started, and sometimes even the cleaning dripping going on, you have given GA and you see that patients are having a vital signs of having temperature, increase of temperature. In that early vigilance, if exercised, I think that can save a life. Because I don't think so you will get dental in everywhere in any institution. And that PG students were asking about the national registry, it's there almost. In ISA app, you can always report there. You can't publish malignant hyperthermia because already published so many times. What extra new thing we are going to do about it? So that's why it doesn't come in reported as a publication in the journals. Otherwise, it's a national data registry. It's there. You can always see the deaths. So these are reported deaths actually by the institutions also. And for the knowledge of all, our team are working with Dr. Pratibha Kane madam and the Medical Legal Society of India. ISA is endorsing that study where we are going to bring this rare disease into the category of rare disease, where the government can also provide some type of financial remuneration to the disease of the kin of the deceased. So they are going to provide that. I think that is going to happen very soon once we bring it into the category of rare diseases in the government registry. So that is another step. But still, then I think availabilities in our countries is very important. And I don't think so that even in the developed country, you will get dentrolin like availability everywhere like that. It's available there. It's much easily available there. But still, I think how many centers we are getting these cases done? Even the 10 to 15 minutes. Those are very vital minutes where entire protein denaturation in the body occurs. You will not get the things go to irreversible stage where you will not be able to reverse the patient back to the normalcy in malignant hyperthermia type of cases. So early vigil is very important in these type of cases. I think if it can save life, and I hope and pray that it should not come into the on the table of every anesthesiologist in India. It should not come, but because these will give a very bad experience and psychological upsetting the anesthesiologist also. That's what I feel. Anything else, Dr. Swati?
No, sir. Everything is covered, sir.
Dr. Raghunandan, he is not speaking nowadays. He's writing in the chat box. He should come and speak himself.
Hello.
Yeah.
Yeah, sir. It was very good presentation, sir, by the PGs, and very good modulation by the moderators, and even Madhuri madam helped them to understand the concept in such good way. And one more thing, sir, for periphery, what would you advise for monitoring, sir? Temperature cannot be monitored in periphery.
Yeah, that's
That
what.
one.
And periphery, the maximum use of scoline occurs till today. The maximum use of scoline occurs, and even now the halothane has stopped. It is also, so at least one drug is off. The only way we can prevent is one is the stoppage of sectional choline when the government stops the ban its production. The next is, I think, in these type of cases, very difficult for me if I'm getting a case done in a peripheral, because if I have got, even if I got a temperature probe, I don't think so. It's accuracy, it's detail in getting that digital reading in a 5 minutes particular rise of temperature. I can only see if there is a tachycardia, unexplained tachycardia, if it occurs, that is the one thing. I think any unexplained tachycardia, fever during temperature rise during anesthesia, that you have to learn over the years.
Okay, sir.
You cannot say that within 2-3 minutes somebody able to pick the things up.
Okay.
It requires a good learning curve also, that you have seen the earlier cases also.
Yes, sir.
That's the only way to go about it. It's very difficult in the periphery.
Sir, sorry, sir. Sorry to disturb you. Actually, halothane has veered off from the periphery now, sir. We are more exposed. Yeah.
No. Its production has stopped.
Yeah, sir.
Production has stopped because that raw material is not getting anywhere in the world now. So production of halothane has stopped.
Okay, sir. Okay.
That's the one thing. So I think they will come, then scoline will be away. But scoline, I think, is a wonderful drug in many circumstances.
Yes, sir.
I don't want that drug should go for us, because it is a life-saving drug also in many cases.
Many cases. Emergencies, it is a very useful drug, sir. Life-saving.
Yeah, that's why it was a very tricky situation for me. How to go in the periphery. So it's all depend upon the clinical visual, the clinical skills of the attending anesthesiologist.
Thank you, sir. Thank you very much.
I think the class is over now. So we shall be parting now. Next class we will be having on neuro monitoring. Today we had a temperature monitoring. Next we have neuro monitoring. After that we will see another monitoring standards. So thank you, team Solapur. We are very grateful to you. Nilamri ma'am, your team, and I think PG's almost got a pre-final run today, so they will be appearing in a good colors during the examination. Best wishes to you.
Thank you.
Thank you. And always end by saying